Good evening, everyone. Thank you for joining us for our September webinar with the Scleral Lens Education Society. Today's webinar is going to be on scleral lenses, practical approaches to improve clinical efficiency and patient outcomes. So we have two awesome speakers tonight. First, we have Dr. Karen DeLoss. She is an associate professor at the University of Michigan Kellogg Eye Center in Ann Arbor, Michigan. Her practice primarily concentrates on specialty contact lenses for corneal hypoxia and ocular surface disease, and her research is focused on clinical outcomes of specialty contact lenses and anterior segment disease. Dr. DeLoss has published several manuscripts in the American Journal of Ophthalmology, Contact Lens and Anterior Eye and Contact Lens, and Cornea. She is also the vice chair of the program committee of the Global Specialty Lens Symposium and is currently the chair of the Maintenance of Fellowship Committee for the American Academy of Optometry. She's also an advisory board member for the Gas Permeable Lens Institute, serves on the American Optometric Association Cornea and Contact Lens Committee, and is an advisory board member of the Scleral Lens Research Meeting. Dr. DeLoss writes a column every 2 weeks for the online newsletter Contact Lens Today, and she's a contributor to the GP Insight section of the Contact Lens Spectrum and other monthly sections. She is also a journal reviewer for many journals, including Cornea, Optometry and Vision Science, Eye and Contact Lens and Anterior Eye, and Optometric Clinical Practice. Dr. DeLoss obtained her undergraduate degree at the University of Wyoming and is a graduate of the Illinois College of Optometry. She then completed her fellowship in cornea and contact lens at the University of Houston College of Optometry, and also completed a clinical fellowship at the Boston Foundation for Sight. Dr. DeLoss is a fellow of the American Academy of Optometry, a fellow of the Scleral Lens Society, and she lectures both nationally and internationally on subjects related to her clinical practice and research. We also have Dr. Jamie Kuzniar, who is the owner and founder of Elevate Eye Care and Eyewear in Rochester Hills, Michigan. She received her doctorate of optometry from the Michigan College of Optometry and completed a postdoctoral residency in cornea and contact lenses at Indiana University. Dr. Kuzniar is a fellow of the Scleral Lens Society as well as the American Academy of Optometry. She has been the recipient of many awards, including the Clinical Excellence in the Field of Gas Permeable Contact Lens Award from the GPLI, the George Mertz Contact Lens Residency Award, and she was voted by Newsweek as number 25 on their list of top eye doctors in America in 2021. Very exciting. Dr. Kuzniar is a consultant who lectures nationally to students and doctors, teaching them about new technology and specialty contact lenses, dry eye, and keratoconus. Thank you guys both for joining us tonight. I'm very excited for this lecture and can't wait to hear all about it.
All right, thank you so much to all of you for joining us. And thanks for that great introduction, Roxana. So just to start out, here are our disclosures that we have for tonight. All right, so just to kick it off, so some of our goals for today, we really just hope that you take away a lot of really great knowledge and practical knowledge that you can use in all of your practices, no matter what modality that you have. So the first thing we're going to talk about is how to build your scleral lens practice. And then we're going to talk about how to actually optimize your schedule for your new scleral lens patients that you have. Okay. After that, we're going to talk about optimizing your staff training so that you can get the best patient outcomes. We'll talk about long-term management of scleral lens patients. And finally, we're going to talk about effective management of common symptoms and fitting issues after wear so that those patients don't drop out of scleral lenses. So starting out with building and growing a scleral lens practice. So depending on what modality that you are in, this could be a little bit different. So when I had first started out, I had joined a group practice, okay? So when I had joined a group practice that had been established in the area for a while, I got a lot of my patients based on referrals. So I looked to local optometrists, either within the practice or outside of the practice, that actually didn't fit scleral lenses. So what I actually did was I went out to a lot of like corporate optometry offices that maybe don't have the resources to fit scleral lenses in office. And just let them know that, hey, I'm new in the area. I'm fitting scleral lenses. If you have patients like this, feel free to send them my way. Also, I was really into going into day dates with ophthalmologists. So basically I went to lunches, I stopped by their offices just to tell them I was new in the area, that I fit scleral lenses, and telling them the indications about scleral lenses. So what I found a lot is when I met with a lot of ophthalmologists, the first thing they would say is, well, that's really great. However, I don't have a lot of keratoconus patients. But they didn't realize that scleral lenses could be used for more than just keratoconus. So when I talked about how it can be used for dry eye, they can be used for neurotrophic corneas, they could be used for herpes simplex or zoster scarring. I think it really intrigued them. And I started to get a lot of unique referrals from just general ophthalmologists. Obviously, corneal ophthalmologists are going to be your main source of referrals as well. Sometimes it's hard to really break into those. So what I did a lot was a lot of networking. Okay. So even going to a lot of different dinners, CE events locally, just getting your name out there. And then word spreads pretty quickly that way. However, what I'm doing now is I actually just started a cold start a couple weeks ago. So my marketing is a lot different. Now it's using, Google ads, using social media ads, putting on your website that you fit scleral lenses so that when patients who are looking for a provider find you, asking patients to include the word scleral lenses in their Google reviews. It might sound a little cheesy to ask patients to review you. However, that really just helps other patients find you when they're just looking to the internet to find their new doctor. Now, talking about scheduling, and scheduling is going to be a little bit different. And Karen and I talk about this as well. So scheduling in my office is different than scheduling in a hospital-based clinic. So looking at private offices typically you have a little bit more flexibility in your schedule. What I typically tell new doctors starting out, especially if you're new to scleral lenses, is always plan for more time than you think you will need. Okay. So I usually recommend fitting patients for about an hour-long slot. Okay. What that does is it makes it so that you don't feel rushed and you don't feel like you're running behind for your routine patients that are waiting in the next room, wondering why it's taking so long to get their doctor in the room. So if you start out with an hour, that gives you plenty of time so that you're not rushing, you're not forgetting to write down certain aspects of the lens fitting, and gives you better outcome in the future. However, once you get more experience, typically you can reduce that fitting time down, okay? You can do that by adding technicians to maybe help with the fitting. Having them put the first initial lens on is really super helpful. If they can do the teaching, like insertion removal training, if they could do some of the pre-testing, that way you don't physically need to be in the room with the patient as long, but you still get that really great outcome. I often would use multiple exam lanes. So what I tell offices too is you don't need to be sitting there the whole 20, 30 minutes while the lens is settling. What I would typically do is, talk to the patient. Once they did all the pre-testing, I would put the first lens on, and then I would tell them, I'm going to let this lens settle. I'm going to come back to take some final measurements, and then I would leave the room. And when I left the room, I could go to another exam lane and I could see a med check patient. I could see a full exam. I could check the dilation. You don't need to put a huge block in your schedule. You can still remain efficient, but still allow enough time to do that proper fitting. Another key that I found is having all of the patient's information right in front of you about insurance and pricing, okay? If you have all that information beforehand from your front desk, you can know if they are eligible for medically necessary coverage with their plans. You can say right away when you're talking to a patient, hey, you don't have to worry about if this is covered or not, because I know right now it's covered, okay? If you have to talk about cost or pricing, it really helps your flow if you know beforehand, if possible, it's not always possible, to know if they want to proceed with the fitting or not. So, and a lot of times if you're talking to the patient about it and maybe they're hesitant, I've had times where patients want to think about it. And I say, that's totally fine. Maybe you just start out by doing a consultation and then they come back for a fitting appointment when you have more time. You just don't want a patient sitting there, calling a lot of people, texting their family, deciding if they want to do the scleral lens fitting or not. You don't want them to feel rushed. So a lot of times you just have them back on a separate day. So this is a little bit different from where Karen is working at. So I'm going to have her talk about how they do things in a hospital-based clinic.
So, hospital-based or ophthalmology practices, you don't necessarily have control of the schedule per se. Or the other thing is ophthalmologists tend to see way more patients than optometrists do. So they don't necessarily understand the flow of things. So it depends on the practice. I agree with Jamie. If you can start with 1 hour fitting and then kind of piggyback those by seeing kind of a short visit or routine eye exam or contact lens follow-up so that you allow for flow. Ideally, while you're waiting or seeing another patient, you can have the techs do the topography and workup, and we'll talk more about that in a couple extra slides here today. And then I also have I have my techs do over refraction, help with insertion, loose lens trials, that kind of thing. So we'll talk more about that in a little bit, but it really depends. I think right now I get about 15 minutes to do a scleral lens fit. So, and that has nothing to do with proficiency. It's just that's how our flow goes currently. So, but luckily I've had 12 years to build on that.
For sure. So then looking at the fitting timeline, the first thing that we like to do is do an initial consultation. So for me, this kind of depends, for some patients, if they're in their routine exam, I have them back on another day to do the fitting. It's hard to get a full comprehensive exam with dilation and a fitting. It's just a long time. You don't want to drag your whole schedule behind. Okay. As I've gotten more efficient, I can typically do a fitting with a routine exam just because I've learned to do that over the years. But usually when I recommend doctors that are starting out with sclerals, just break them up and do them on separate days, okay? If a patient's being referred in, so if someone comes in with exam records in hand, or they came from an ophthalmologist, something where they've already had a full exam, you can easily just fit that patient the same day. So during my consultation, I basically go over their condition in general, because it's amazing how many people come to you for a consultation and they have no idea why they even need sclerals. They don't know what keratoconus is. They don't know anything about their graft. So I like to give a little bit, synopsis, elevator talk about their condition. I go over the basic of a scleral lens. I talk about how it's a large diameter lens that's going to be really comfortable. It's filled with sterile saline. I go over all of that with them. I go over pricing. I just personally choose to do that myself. A lot of offices have staff that can do that as well. I talk about expectations for follow-ups, because a lot of patients think, great, she's going to order this lens and I'm going to pick it up next week and then I'm done. So I want to let them know, especially for your first initial scleral lens fitting, we will be seeing each other a few times over the next 2 months. So that way they know we're not starting this fit before they fly to Florida for the winter. Okay. I want them to know that I'm going to be seeing them a number of times over the next couple months. And then I also go over the warranty period. I go over this so much just because I don't want patients to fall off the face of the earth for 2 months and then come back and say, oh, I never wore this lens. I want it to be changed. So I really go over the fact that, hi, I'm going to order your lens today. Okay. We have X amount of days to make any changes that you need to the lens. And I bring that up because it's really important for you to know that I can make any changes we need to make sure you're comfortable. But I also need you to adhere to our follow-up schedules. That way you get the best outcome.
Yeah, I was going to say, I'm pretty much the same as Jamie, except for we look into insurance after the patient decides to go forward or not. And so we look into that after. So that's the only difference. And I cannot emphasize enough about the warranty and the expectations, both expectations for follow-up and also expectations on what the patient can expect. They don't, in terms of not a miracle, but a treatment or something like that.
All right. And then after the consultation's done, so after the patient has decided, I want to go through this process with you, doing the initial fitting. So ideally, if you already have the topography and all of that done during the consultation, you'll know exactly which trial lens you want to apply for the patient. Okay. So typically before the patient comes in, I'm going to look at their topography. I'm going to look at the overall shape of their eye. What am I fitting here? Am I fitting a typical cone? Am I fitting a graft? Am I fitting an RK patient? So that way I know exactly which lens to apply. Or if you have a technician, a lot of times you can even say, when that patient comes in the room, I want you to put this trial lens on the eye, and you can have that there and settled before you even walk in the door to really save on time. Really important to check for things like bubble, touch, anything significantly wrong with the trial lens. As long as the lens looks pretty good initially, I just let that lens settle. Okay. and then do your over refraction and any little fine details that you need after that. What do you say about that, Karen?
Yeah, I totally agree. And then the only pearl I have in there is that, you know, when you initially, the first thing I do is tell the patients that these are our lenses. They're not designed for them yet, but we will get there. And so I emphasize that if you look up and can't see, don't worry, we'll work on that. And so a lot of times with the trial lenses, you have to do large changes for over refraction before, and I'll say it's going to be like lights on. So you just kind of keep moving plus and minus until you kind of bracket it to a point where the patient is like, oh, I see it.
Right. I know. I always have to tell people that too. And no matter how many times you say this is not the exact power for your eye, like over half the patients are going to say, it feels fine, but I can't see anything. And I was like, yeah, I usually say that's just like buying picking up a pair of pants at the store and it being the perfect fit. It's probably not going to happen, but we'll get there for you. So yeah, setting those expectations ahead of time. And then once the lenses come in, okay, for the dispense appointment, there's a couple different ways that you can do this. So depending on how my schedule has been over the last few years, I either will call the patient when the lenses arrive, or when my schedule's been really full. Sometimes I've just chose to schedule the patient ahead of time. A lot of the manufacturers that I use, I know exactly how long that lens is going to take to get here. So I'll just say, all right, let's schedule you for 2 weeks for your dispense appointment. There's pros and cons to that. Okay. So if the lens doesn't arrive for some reason, that's not a great situation. Okay. However, I've had issues where if I say I'll call you when the lens arrives, I've had patients that just dodge our phone calls and don't come to set an appointment, and they end up using 2.5 months of their warranty because they never even came to their initial dispense appointment. So that's where it gets a little bit tricky. I know that, I think, Karen, you said that you guys call when the lenses get there because of insurance and having to go through all of that.
Yeah. So because of the system, we call the patients when the lenses arrive and then schedule so that we don't have patients that are coming for an appointment and there's no lenses there. So that's how we handle that. And then for the most part, pretty much the same as what Jamie said.
Yeah. And then at the dispense appointment, typically the flow that we like to do, right now, I insert the lens myself because I do not have a technician. So I put the lens in, and then while the lens is settling, I actually have them watch an insertion and removal video. I think it's perfect for them to sit and do an activity like that, because it allows time for the lens to settle. They're not thinking about every aspect of the lens and like analyzing the vision immediately. But it also helps for when they go to do insertion removal training after I assess the lens. Then it's a little bit faster and a little bit easier on my staff. So I'll have them watch that video. I'll do my assessment and make sure that the lens is dispensable. And then I have them go to their INR class. It's really, really important that you set aside time for your technician to do that training as well. You don't want that patient to come in at a time when you know the technician's going to be running a visual field or some other test that takes a long time. So what we've found, and what Karen does as well, is that you just having a tech specific calendar so that way you know that there's enough time set aside for that patient's insertion and removal. It might be important to consider even specific time slots for new wearers, maybe having them first thing in the morning, last patient before lunch, or at the end of the day. That way, if they do need a little bit of extra time, you don't feel pressured by the rest of your schedule from your other established patients. And then looking at staff training. So I really believe that your whole staff within your practice really needs to be all in on scleral lenses, okay? And this starts at the front desk. So I think a lot of times we think only about the technicians and the doctors, but really, really spend the time to talk to your front desk about just the basics of scleral lenses. They don't need to know how to fit them. They don't need to know everything about them, but they do need to know that you fit them. They need to know what are common things that someone might call in and say about their scleral lenses. So if they say, hi, I'm a patient that has keratoconus, do you fit lenses here for keratoconus? You want your staff to say, oh yes, we fit that all the time. You don't want them to say, oh, I've never heard of that. Let me ask or let me double check. If they don't know the answer to something basic like that, the patient is going to think, wow, they must not fit a lot of keratoconus patients here. I'm going to find another office. So just knowing things about, keratoconus, knowing corneal transplant, knowing key words that the patients might say. A lot of times they might not say the word scleral lenses when they call, okay? Also really important to know about scheduling. So don't schedule them as like a normal soft lens fit. Know to schedule them in a fitting time that takes a little bit longer. I also like to know a little bit about fees and medically necessary coverage as well, okay? Many patients that I see, they end up not having to pay for their scleral lenses at all. So I don't want my staff quoting, prices over the phone when really they have full coverage under one of their vision plans or medical plans. So a lot of times patients might get scared off by that and think, oh my gosh, this place is super expensive, I can't afford it, when really they only have a small copay out of pocket. So just so that they are aware that these lenses are different than, soft lenses that you've been fitting in your office or from other offices that they've worked at. I think it's also important for them to know a little bit about solutions and some of the tools, because I have a lot of times where patients will just walk in without an appointment, walk right up to the front desk and say, which solution, what are we supposed to be using to clean, these lenses, and what are we supposed to be using to fill the lenses? Or if they don't know the answers to it, know enough to grab one of your technicians to ask and answer that question for the patient. Because that way it just really shows that your whole office is on the same page for scleral lenses. And then moving on to technicians. So technicians are going to have to know, I feel like, the most about scleral lenses. So not only do they need to know the basics and the disease types, they need to know how to take really great like topographies, baseline images, OCTs. That would all be ideal and fantastic. They need to know a lot about teaching insertion removal and lens care, and knowledgeable about different types of INR. So not just using the two plungers, maybe using something like a stand, using something like a ring applicator. I like to have my technicians practice putting the lenses on each other and on themselves. So that way they know what the lenses feel like and that they are really comfortable lenses. It's not anything to be intimidated by. And also so that they realize, especially if they have a trouble inserting the lens the first time, when they're teaching a patient, they can say, when I was putting this lens on the first time, I was a little bit nervous too, or it took me a few tries. And then it can really help the patient to relate to them really well. And then looking at like your opticians. So with opticians, no, it's okay. We'll talk first about INR. So you can go to the next slide. So talking about INR. Okay. So I know we just mentioned, having them train on each other and having them know the knowledge of not just using the large and small plungers, knowing the different methods. Okay. Every single patient is going to need something a little bit different. Okay. I think it's really helpful if I put the lens on the patient first, or a technician does. That way the patient isn't intimidated by the size of the scleral lens. I think a lot of times if an office has the patient just try to struggle with INR before they can even experience how great their vision is and how comfortable the lens is, they start out with a negative experience. So having them start with the lens on, and then I bring them out to the insertion removal area and I have them learn how to take the lens out, which is typically easier. Okay. So starting out with a win in that aspect. There's a lot of really great resources online for both your staff and for patients. So there's a great INR video, and I'm going to show you a link to that towards the end of this presentation for the patient to watch in the exam room like we talked about. But there's also a lot of great resources online for your staff to learn as well. Okay. It's really important that the staff and the patients both have patience. Okay. Let them know that they might have to come back for another time to have the class completed. If they don't get it immediately within 5 or 10 minutes, like their soft lenses, that is completely normal. So you really need to have a staff member that has patience, that is encouraging to your patients. That way they don't feel discouraged or say, I want to drop out. This is too hard. I'm just going to go back to my gas perms, or I'm going to go back to just wearing glasses. You need someone that's going to do a little bit more hand holding, I guess you could say. It's also really important to have handouts about your care products and instructions. I cannot tell you how many times, patients say, I understand, I get it. And then they get home and they don't remember, what am I supposed to be using to fill the lens? What am I supposed to be using to clean the lens? And we see, a lot of us see this when we go on our Facebook forums for scleral lenses. Patients are on there looking for information, and a lot of times that's not correct information. So giving them something tangible to take home So that way they can actually look back and reference it throughout the first week that they're learning their lenses. So now to opticians. So opticians, they do not escape my staff training, okay? I think it's important that opticians at least know about scleral lenses for two reasons. One is that they don't use their glasses benefit before I bill out their fit, especially if using vision insurance, okay? If your optician pushes through a glasses order before you can push through that scleral lens order, it will use the scleral lens benefits, and it will become a huge nightmare for you to try to reverse the claim, go back, and it's just not fun, okay? So I really hammer that home with my opticians that this patient wears scleral lenses. So they're going to be using their insurance for their contact lenses. I've hammered that home just because I'm sure many of us has had that situation when you go to put the claim in for your scleral lenses and it's denied. The other thing is, so that they understand what the patient expectations are for vision, okay? No matter how many times, I'm sure you've experienced this too, Karen, you show them in the room when they say, I also want a pair of glasses, and you show them, this is what your glasses are going to look like. Then they order their glasses, they pay out of pocket for them, and then they come back and they say, I can't see like I do in my scleral lenses. That way your opticians can say, well, remember, you wear these medically necessary contact lenses and your vision is going to be better in your contact lenses and your glasses. So that way you don't run into all these RX checks and unhappy patients because of their backup glasses. And we've chuckled at that. I'm sure all of us have run into that. All right.
So I'm going to be, well, go ahead, Jamie.
Yeah. So, and then next, I'm just going to kick it over to Karen, and she's going to talk a little bit about some of our follow-up appointments.
So kind of then taking it from the next step of training and staff, it's kind of how do you do your flow with your patients. So we talked about the initial consultation, but then when do you do your follow-up? I usually have my patients return in about a week. Jamie, how often do you have your patients come on after you dispense?
So I like to have them back in 1 to 2 weeks, kind of depending on their schedule, and my schedule as well. So 1 to 2 weeks, that way it's not, they've only worn it for a day or two. I want them really to get used to wearing the lens.
Yeah. So I usually have them come back, and the best thing I can do is tell you is have patients bring a list of questions. That's bit me in the behind a couple times, but it usually is really nice for a lot of our scleral lens patients are a little bit anxious, so they can come in with their list, and sometimes the technicians can answer those questions before I come in the room. So that's really helpful. But that's an opportunity for them to feel at ease, and then they don't feel like they have to have everything answered right then and there. Ask open-ended questions. So how is it going? How are things? How is your vision? So you don't want to have too targeted on your questions right away. You'll have an opportunity to ask that a little bit more as you go forward. And then also have the patient explain comfort. So is it comfort? Is it dryness? Is it, you want to kind of tease that out of the patient. And then have the patient explain their nightly cleaning regimen, because a lot of those patients, like Jamie said, they will go home and yeah, I got it. And they come back and they're using everything wrong in every direction. So that's really helpful for them to explain that. So your history is kind of your typical history, but obviously you want to ask about their vision and then open-ended, and then start narrowing it down. So is their vision good or bad all the time? Does it happen towards the end of the day? One of the things I want to emphasize is if it happens towards the end of the day, you want to elucidate a little bit more because you want to watch out for particularly post grafts to make sure that they're not having any edema underneath their lens. Comfort. So are you happy with it? Is the comfort great? Is it discomfort, or is it pain? So those are things that you want to ask. Fogging, we'll talk about more about that in a few more slides. And then discomfort, is it after a few minutes? Is it towards the end of the day? And where is it located? So with your follow-up exams, you're always obviously going to check vision, but make sure that you're over refracting each time, because on those next follow-up visits, you may get minor changes. And some of my patients will go back and forth, particularly keratoconus patients. They kind of may bobble up and down. So you want to make sure that you record everything every time. so that you can say, oh, you're flipping back and forth or something like that. Pinhole your patients. The other thing is I always do a spherical over refraction first. I don't jump into a sphere sill over refraction until I have to. I pinhole my patients to make sure that their best possible vision has been achieved. And if they pinhole better, that's an indication where I do a sphere sill over refraction. Then you want to jump to your lens evaluation, conjunctival staining, and corneal evaluation. So inside out, so you're going to start from the front to the back. So front surface, you're looking for wetting defects and debris. You're also going to evaluate the vault to make sure that the clearance is acceptable. You are looking for ideally about 200 microns, little under half the width of the cornea, or reservoir debris if they're complaining about fogging or something like that. The scleral zone, so you want to look at the edges, and then add fluorescein to see if you can see any tear exchange. That could be an area where debris can be getting in, but then also that could be an area where if you have suction, you're not getting any tear exchange. That could be a problem too. And then remove the lens yourself, and I'll talk about that more. I want to give a shout out to Dr. Lynette Johns because she and I did a lecture together, and she gave me a lot of images. So I want to make sure, and I think she's on tonight, so I want to make sure that she gets some credit tonight. White light evaluation. Jamie and I are both low tech people, but one of the things is your patient's going to come in with the lens on, so you can't see that lens with fluorescein when they first come in. So get comfortable with white light. You want to be able to see the front and the back surface of the lens, as well as that shadow in between. And make sure that you have an estimation for the vault or sag assessment. And it also allows you to look for edge lift or a area where the debris is coming in. If you apply fluorescein, you can actually look for a channel or a flow. So this is just a little bit of the basics of scleral lenses, and I'm sure it's been covered in other lectures, but obviously you can see here, you're looking at the front surface of the lens, the gray space in between, and then right here, you're looking at the cornea, which is an optic section. So compression is something that a lot of people can miss, and it can be fine. And I want to emphasize there's two different types of compression or impingement, and then the terms are defined by the Scleral Lens Education Society, but you just want to make sure that the vascular flow is even. So the two pictures on the left are showing areas of compression where that blood flow is kind of sealed off. One is more on the edge, and then the mid-haptic compression on this bottom picture is showing that the lens kind of dips down and impedes the blood flow. And this, sometimes you won't see it. You want to have the patients look left, right, up, and down so that it'll highlight it in any direction. And that'll be an indication that that could be an area where there's a fitting issue, but also you want to fix those right away because those can cause problems long-term. True impingement. So these are where the edge is actually digging in, and I'll show you a way to look for that later. But both of these pictures you can see right at the edge. That's obviously too tight in that area. That's a common area that's common for people to miss. The other area, though, this one is less common, and people do miss that quite a bit. So short-term impingement, basically when you take that lens off the eye, you're going to see an arcuate defect. And so that'd be an indication. If you see that, you definitely want to change that right away by lifting your haptic in that area. Excessive edge lift. So this could be a source for debris to come into the lens. It also could be discomfort area, and that's common when you see it. That's usually an area that you want to fix right away as well. Early indications of success versus struggle. So one of the key things is daily wearing time. I've had patients come in and they're not wearing their lenses, and you start probing them a little bit more and they just don't feel comfortable with insertion removal. Does that happen to you, Jamie?
Yes, it has double trouble. I remember having a guy come in saying, I cannot see anything out of these lenses. And he drove all the way in, there was just a huge bubble. And he said he couldn't see anything for the whole week. So it was just, and as soon as I took the lens off and put it back on, he was like, oh my gosh, it's magic.
Yeah. So if patients complain of discomfort right away, there's a couple different things that it could be. It could be that the vault is touching right away, but usually if it's comfortable initially, and then gets uncomfortable over time, that's usually an indication that the lens is settling on the eye and touching the cornea. or there's a bubble, and they won't feel the bubble right away, but as time goes on, they're going to say it really, really hurts. And so those are the patients I explain to them. It's like, well, you've got a bubble, and it's like having a hairdryer, focal hairdryer on that area of the eye all day long. And that's something that's tangible for patients to understand. Front surface debris, I tell my patients at every initial encounter that I have with them that this may happen. And it depends. It's more common with ocular surface disease versus keratoconus, but keratoconus patients can also get that. The picture on the right is a patient with exposure keratopathy. I definitely warn all of my exposure keratopathy patients, because they're not blinking, and also all of my GVHD patients, that they're likely going to get surface debris, and they're going to have to take the lens out and clean it and put it back in. Jamie, do you have additional comments?
The hardest part with this, especially for dry eye patients, is, we fit scleral lenses for dry eye patients to help with their dry eye, but then of course we get this surface debris. So, as hard as we can try, a lot of times it's just trying to treat the underlying condition and have them know, like you said, you might have to take the lens out and clean it. You might have to be using, lubricating eye drops throughout the day. I just had someone this week that came in and said, nobody could figure out why I can't see out of my scleral lenses. And there was just all this front surface, just gunk on there. So, maybe, I'm sure other doctors have told her that, but, maybe even talking about different cleaning products, or using like an enzyme cleaner or something to help with that.
Have you had any luck with mucomist?
I haven't tried that. Have you?
So I bring that up because I've had patients ask about that, but I haven't had much luck with it. I find that it just kind of, it's the underlying condition that is the problem.
Right.
So we talk about squeegeeing to get, there's pros and cons to squeegeeing, and some people, I will sometimes have patients take a Q-tip and wet it and have it wipe that down. The squeegee effect has pros and cons. Jamie and I were talking about that before we got going for this lecture, and she kind of indicated some concerns.
I only let patients squeegee that I trust with the squeegee, because I don't ever squeegee with the plunger, because I just had too many people that try to use the plunger as a squeegee and then end up like pulling the lens off or getting it stuck in the middle. So I prefer them to use a Q-tip to squeegee. I mean, I've squeegeed when the trial lens wasn't wetting well. Instead of having it resettle again, I've just squeegeed a little tiny bit to get my over refraction as well. I think it's very patient dependent.
I totally agree. You just went over the wetting defects, but usually it's just a matter of them having to just clean the lens a little bit more. So that's a pretty easy fix usually. Chamber debris, it depends on the patient, it depends on the etiology, but that's going to be debris underneath the lens, so not on the front surface. And you can see that in this first picture. It's basically, I mean, there's been a lot of research on it, but I kind of tell patients it's kind of like a mousetrap where the debris can get in, but it can't get out. And so that's where I'm warning them that they have to take the lenses out, clean them, and put them back in. There's a couple tricks that you can help reduce all that. Care and handling. This is a patient of mine on the top that came in with a subconj heme due to poor insertion. So I want this to serve as a warning picture to anybody that's watching, because patients, a lot of the technicians or people will say, oh, you're good enough, you're good, because they get tired, and Jamie emphasized the patients. But I want to, write home about this picture, because this is a patient that had like basically a conjunctival laceration. So scleral lenses can be possible problems for patients, and you want to make sure that they're comfortable in insertion removal. Be able to, you also want to ask about their filling solutions, what they're filling their lenses with, the rewetting drops, those types of things. I've started to ask about plunger disinfection, because I don't think that we necessarily talk about that enough. We talk about contact lens case replacement for soft lens patients, but I don't think we're talking enough about plunger disinfection. Usually alcohol wipe or soap and water is what I tell them. Be able to do insertion bubble identification. So you can have patients get a flashlight or like a small pen light and make sure that they have aware of that. If they're having problems with bubbles on insertion, I have the patients just go through what I call a refresher course. where they go back and do a little bit of training. And so they can identify some areas that maybe need to be tweaked a little bit. With removal, ask about redness after removal, discomfort, and loud noises. Those can be big key indicators of either a fit issue or a patient issue. So loud noises, usually it's the patient is just pulling that plunger right directly off the middle of the lens. So that can cause breakage over time. It also causes a lot of discomfort because the patients are pulling right from the edge. So you definitely want to ask a few of those questions. Evaluate the lens for suction. So if the patient says they're difficult to remove, take it off yourself. So obviously you're going to put fluorescein on there and look for fluorescein exchange and just even a little tiny window. If you don't have any fluorescein uptake, there's complete suction. So that's one thing that you can look at to see if you're fit, because you want to have a little bit of exchange. But it also depends on the patient. If they don't have any much of a tear film to begin with, it can be hard to see that. But also take that lens off yourself. Jamie and I have different ways of removing it. But if it's easy for me to take off, then that's a key indicator that it's the patient that is having difficulty with insertion removal, not my fitting issue. And I always ask that too about patients who have been fitted elsewhere, about that, if they had difficulty removing the lens, and that can be an indication that maybe they didn't have a great fit. I like to remove from the top. So I have the patients hold their lid. I hold their lids and take it from the top. Jamie's the opposite.
I like to take it from the bottom. I have the patient, I always say, look at the top of the door frame, right in front of you. And I just hold their lower lid down and I grab it from the bottom. I don't know. That's always just worked a little bit easier for me. Sometimes when I tell people to look down, they like look so down that their lower lid is like holding the lens on. So I've just adapted to removing from the bottom. I think the key is just from the edge in general, whatever works from you. And like you said, just taking that lens off yourself, because I've had a lot of times there are patients like, I cannot remove it, I can't take it out. And then I say, well, let me try it. And it comes out so easily. And then they're just amazed, like, oh, okay, maybe I do need that refresher course.
And I'd say 9 times out of 10, the patients are trying to remove, they're putting the plunger too far in. So I usually just make sure that I ask them, where are you taking the lens out from, and try to direct them towards the limbus or farther down.
Yeah, I always I spy on my patients when they take their lenses out too. Like I pretend like I'm typing over here, and I kind of watch them take their lenses out, or I listen, because if I hear them just popping those things out, it just makes me cringe. So yeah.
So assess the cornea without the lens. So staining, you want to look for a focal aspect, or focal area is just going to be an indication that there's a bubble, but you would have seen the bubble already. Diffuse, consider solution toxicity. So more times than not, I see that patients are filling their solution with a multi-purpose solution is when I see that the most. Epithelial bogging, which is, there's a picture here and here. That can be, sometimes it's just the patients don't have a great ocular surface, but a lot of times that could be suction, meaning that your lens is too tight, but it's minimally tight. Neovascularization, you want to obviously record anything initially when you first see the patient, because I've had ophthalmologists say that, the lens is causing this. And I say, you know what, actually I documented that 3 years ago. The other thing is, I've got this picture on the right here, because with ocular surface disease, you may need to get comfortable with red eyes. So the picture in the middle here is just showing kind of an active neovascularization, versus on the right, you've got just straight fingers. You've got kind of just normal neovascularization that you want to monitor, but it's not necessarily something that you can control.
Yeah, I agree. Totally. Taking the pictures too. Anytime I see any kind of neo, or especially like graft patients, if they have blood vessels close to the graft, I'm not going to remember exactly where that was when I see them in 6 months. So I just like having a picture, even for just reassurance.
And if you don't have photography, just make sure that you're charting in as much as possible in many details. Another thing, when you take that lens off, make sure you evaluate the conjunctiva. A lot of people don't stain the cornea and the conjunctiva to look for areas after that initial lens dispense. And you can really pick up on some key areas where the patient was having difficulty. And then also look for rebound hyperemia. If you're fitting neurotrophic patients, they may not have they don't have any sensation in their cornea. So this could be a key indicator that there's a fitting issue. After you take that lens off, take it back and put it under your radioscope or your lensometer. I tend to just look at under the lensometer to see if it's warped or something like that. And that's for more long-term patients. The other thing is, if you over-refract and you don't get a good endpoint, that means that lens is warped. You can do overkeratometry and other things. What types of things, Jamie, do you like to use for determining, the status of that lens?
A lot of it too is just kind of like looking at it down their eye. I mean, if you see a lens that has like a lot of scratches, and they clearly are not taking really good care of their lens, it's probably more of an indication that that lens is older and probably warped. I see a lot it's amazing. I can have patients that their lenses are pristine for 5 years. And I have some people, when they get to the year mark, and it looks like it's been through the war. And I don't know what they're doing. One little tip, not necessarily with warpage, but with scratches. I've seen a lot of patients get a ton of scratches on their lenses because of their clear care cases. And I had a patient that would put her lenses in clear care and shake them up to get them extra clean. And it was causing so many scratches, or they'll put it in the clear care case and then throw it in their pocket. And they get jumbled around all the time. And I think patients don't even realize that they're doing some of these little small things that are just wearing down their scleral lenses even faster.
We're getting short on time, but the other thing is hypoxia. So this is a patient of mine that has a failing graft. And so you want to identify whether it's microcystic edema, stromal edema, et cetera. And then watch for neovascularization, but these are going to be pretty obvious issues. The patient's not going to be able to see. It's more of a problem towards the end of the day. And so those are ways to, it's easy to identify. Troubleshooting for hypoxia in particular, and grafts. I like to do pre and post pachymetry so that I have that, so you can see if the cornea is swelling throughout the day. If you have endothelial cell count, that's ideal. General rule of thumb is if it's under 1,000 cells per millimeter, but that is not necessarily a hard and fast rule. Obviously, something like Miro can be used. And if you have a patient that you're really concerned about, I do a challenge where I put the lens on the eye and have them wear it for about 4 hours, and just to make sure that that cornea could withstand it. So those are with your older grafts though. If they have entering edema, I just tell them right away that it's not a good idea to fit a scleral lens because it will only get worse. Again, with troubleshooting, you definitely want to make sure that you photo document everything. If you have any concerns with hypoxia, you're going to optimize the DK, reduce the wearing time. That's a possibility as long as you're kind of talking, usually you're talking with co-managing with an ophthalmologist at that point. Minimize the central clearance, increase the limbal clearance. I tend to refit large and loose if I can. And you also can consider fenestrations, but I think that is another lecture. Corneal limbal staining, I kind of talked about this, but focal staining, suspected bubble, diffuse staining, solution toxicity, or even herpetic issues. But again, and then the epithelial bogging here, you may look for suction as a possibility as well. Bulle is another thing, or bogging. So this is an area where you definitely want to try to loosen your fit if you can. So again, for troubleshooting of those conditions, increase apical clearance. So if you have a focal area that it's touching, it's going to leave a mark. So increase your apical clearance. Increase your limbal clearance because you want to protect that area for nourishment and make sure that the cornea is able to heal itself. Fit it loose, like I said, and increase the diameter. Is sometimes people don't always feel comfortable with that. Bubble identification and ensure preservative-free solution. And then preservative-free care systems if needed. So that would be another tip if there's rebound hyperemia or something like that. I'm going to quickly go through staining. So I mentioned that staining is an issue. You're going to see an imprint. So that would be an indication to kind of pull up on that lens. But also then the conjunctiva can be drier in some areas, and then look better in other areas. So make sure that the patients know if it feels not comfortable. Sometimes it's that area that's not covered by the lens. Again, just if you see that staining and you see that mark, the lens is telling you lift it up there. So you might want to adjust your fit. And if you're not comfortable with toric peripheral curves, talk to your consultant. Hyperemia, as I mentioned, when does it happen? How often does it happen? That kind of thing. Usually hyperemia it depends on the etiology of the reason that you fit the patient, but it can be mechanical. It could be a bubble. It could be a fit issue as well, or after removal. So if there's suction and the eye gets really red, that's an indication of a really tight fit. And is it in the lens versus out the lens? So if it's all throughout the eye, if the eye is red all the time, that might be an indication of a systemic flare-up. And so I see that most commonly with GVHD patients. And so be thinking of those types of things. It's not always our fault. So again, ensure preservative-free solution and eliminate any fitting issues. You may want to ask about face creams and makeup. And then again, we can't emphasize this enough. Make sure that you're asking about insertion or removal, because they will go home and they will develop their own habits, and some of those habits can tank their success. Prolapse, Jamie and I were kind of talking about that. It's just basically excess conjunctiva that just kind of gets up under the lens. It can adhere. There's lots of controversy on whether this is a problem or not. I tend to know that it's there, but I think it's risk benefit. So I usually kind of ignore it. Jamie, do you have thoughts on that?
I mean, I try to minimize it if I can, but I don't lose a lot of sleep over it if it's still there. I'm not going to do 10 remakes to get rid of it. Sometimes it just is what it is.
Yeah. And then follow up for long term. It depends on your comfort level. So, if you're not comfortable, if your gut says maybe I need to see this patient back, see him back. If it's a high-risk patient or ocular surface disease, I will usually keep a tighter rein on them initially, so 3 months or 6 months. And then keratoconus patients, you can go a little bit longer. Some of it will depend on the comfort level. And as you get going and seeing more patients and fitting more patients, you'll develop your own little cocktail for that. It depends on the warranty of the lens. Keep in mind that it's important for patients to schedule their annual or come back at least for an evaluation, because if they're happy, they may be, you may not see them for years until there's a problem. So make sure that you educate them. And then, does the patient need a refit or do they need an adjustment? That's another hour lecture is how I would describe it. Again, the re-instruction on insertion removal is a possibility. And then the other thing is it a medical issue or a complication of the lens? So that's one thing that you want to be aware of, is that not all of your patients are going to, with a graft that's kind of questionable, or a patient with more severe ocular surface disease, you probably want to see them more frequently and not keep them on the year mark. So I'll let Jamie quickly go over that. And I think we're getting close to the end. So
yeah, so I just wanted to kind of show you a little bit more of the fitting resources. So the first one that we have, there's this great fit scale from Ferris State University. So if you're first starting out, it really shows you, looking at that optics section, more in detail on how to measure your volts. I think there's another slide that we have on here as well. So both of these are on the Ferris State's website. Really helpful, especially when you're first starting out. And then this is the insertion removal video. I saw someone ask in the chat which one that we prefer, not just because this is a sponsored talk. Scleral Lens Society. This is the one I truly use for all of my patients. It's really great, and it's like about 10 to 15 minutes long. You can find it on the website. I think it's a really informative video there. And then there's also some really great fitting guides as well. So pick up, there's this guide, there's a couple other textbooks on the next slide. All super great. They recently came out. There's good clinical knowledge that's nice and current. So if you are starting to get into scleral lenses and want to dive in, they're there. And then the last thing that we're just going to touch on is just setting yourself up to success with good candidates versus not. Okay. Looking at, what condition are you fitting? Is it a patient that's already 20/20? I think my least favorite patient to fit in a scleral contact lens is a 20/20 keratoconus patient. And Karen and I both agree with that. It's really difficult to make those patients happy when they already see 20/20 in glasses. And then just looking at your patient motivation, like we talked about, like they need to know that this is going to be a process, especially the first time that they're wearing contacts, wearing scleral lenses. It's going to take a little bit for INR. It's going to take a few follow-up visits. And are they committed to the time and the effort of wearing scleral lenses? And that's going to wrap it up.